Keep in mind, some of these written years ago by like a 5-year-old. Why do giraffes have long necks? Why do giraffes have long necks? Because their feet are smelly. Why did the hamster cross the road? Why did the hamster cross the road? Well, because it was the chicken's day off. Okay. What do you call a really big ant? Just a giant. It does forget gigantic. I like it. All right. We all warmed up? All right, so today, if you look at our schedule, we're going to finish out inflammation. We're going to talk about chronic inflammation. And then Wednesday, we'll dive into tissue repair. And as you saw in the pre-quiz, we were talking about inflammation and wound healing. And you'll see on the post-quiz, we'll be more heavily on wound healing. Okay, so we're going to cover wound healing on Wednesday. Inflammation is a key component of wound healing. So we're already kind of there. But inflammation expands way beyond just standard wound healing. All right, so we're right on schedule. By now, you guys should be getting kind of the flow. Every week, you've got stuff to do on Monday, and then stuff to do by Friday, and then we show up together on Monday and Wednesday, and then you've got your SI sessions here with Ryan. Again, I want to emphasize, I think, the value of SI sessions. There are a couple of you that came into office hours this morning, which is great. I've got an appointment tomorrow, so if you guys can't make the office hours, I want you to reach out to me and we'll try to find a schedule that works for the two of us, okay? Any questions before we begin? Okay. So let's dive into the different types of inflammation. We're going to characterize these in a similar way to how we characterize the processes of necrosis. Do you guys remember that? And when we look at inflammation, we've got a number of different types, and you can see them listed on the slide. We have serous, fibrinous, superlative, otherwise known as purulent, superlative, otherwise known as purulent. That's how you pronounce those. And then ulcers. And we've looked at some of these along the way with some of our clinical examples, but let's just dive into kind of the different categories, basically the 4 main categories. So if it's a serous inflammation, it's very watery. It's protein poor fluid. So that if it's protein poor, what kind of fluid and what mechanism happened out of the vessel? It's protein poor. It's a transudate, right? It's a transudate. So there's a fluid inside of a cavity, and a great example of this effusion of these transudates is a blister. A blister is an example of a serous inflammatory response. Serous fluid is what it's referring to. If you pop a blister, you know a bunch of clear, colorless fluid comes out. Fibrinous. This happens with more extensive injury. There's larger capillary permeability. And so you're going to see proteins. So now you have, instead of transudates only, what do you have? Exudates. Okay, transudates and exudates. So now you get a protein known as fibrinogen that leaks out. And that fibrinogen creates a meshwork or a coagulum where you get a lot of eosinophils that will collect. So that's a fibrinous. This is typically seen in inflammation of body cavities. Now, suppurative or purulent, this one is where you've got exudate that comes from neutrophils. Remember we said the last time we were together, with an inflammatory response, the first cells that respond or show up, our first responders are what? Neutrophils. And those neutrophils are going to have some phagocytic activity. And the second responders, what's the second cell that shows up on the scene? the macrophages, the monocytes that are circulating, they leave the blood vessel and become tissue macrophages, right? That's that abbreviation with the M and like the circle with the line through it, right? That little sort of tattoo symbol that we talked about. So here we've got exudate in suppurative inflammation that's coming from neutrophils. You see necrotic cells there as well. You see cells that have died because the neutrophils have killed them. If there's bacterial contamination, you're going to get pus, right? And that's the purulent presence. That's a word that means pus formation. And the pus is there because it's infected or it's pyogenic. That means it's contaminated with the bacteria. And if you've got a local area that's walled off, that's contaminated with bacteria, it's pyogenic, and you get a lot of pus that forms, then you develop what's called an abscess. And that's a pocket of pus that's of significant size, a local accumulation of pus. And then our last category of inflammation, which we talked about in one of the first lectures, is an ulceration. And this is an erosion of a tissue or organ. It is due to the shedding of necrotic cells or dead cells. So cell injury happens, the cells die, they're shed off, they lose their attachment, and that's an ulceration or an erosion, if you will. All right, so some examples. That lower left, starting with the last one on the list. The lower left, that's a picture of which kind? Which one do you guys seen that picture before? That's the ulcer, right? That's a peptic ulcer. We looked at that in one of the first lectures. So this is in the duodenum, and you can kind of appreciate from this slide, this is where the hole is, right? Here is the normal epithelium. Here's this cavity, and then it picks up the normal epithelium on this side. And so this is the ulceration, this hole, or this erosion. Upper right, that's fibrinous pericarditis over the heart. Fibrinous pericarditis over the heart. And there's a flap that's been created. So you've got the heart in the background, and you see this flap of this pair of pickups, these instruments, otherwise known as forceps. So that's pulling this flap. Usually that flap would cover this, so they're making a window so you can see. This would normally be a smooth surface, but because it's bumpy and inflamed, we know that it's fibrinous. Then the lower right, this is an example of a purulent inflammation of the lung. And this abscess contains a large accumulation of these purple nuclei in this hematoxylin eosin stain section. So we've got H&E here, H&E here, and then we've got gross imagery right here. And all of these purple dots are all the neutrophils that have infused into this purulent inflammation of the lung. And you can't really tell here because we're at the microscopic level, but if you sort of see this delineation where all of these purple dots are clustered here in the center, there's this kind of delineation here where there's a little bit of a fibrous capsule, and then these red areas are all blood vessels. So the blood vessels are on the periphery, and this walled off area is creating this region of an abscess. So it's a purulent infection with an abscess, a local accumulation of pus. So we're going to see on Wednesday that the inflammatory process is so critical to kicking off wound healing. And we're going to look at outcomes. We're going to see that there's a couple of different things that can happen once you stimulate inflammation. And again, inflammation is a normal response. Remember, it's your second line of defense. You guys remember that? What's our first line of defense? Barriers, okay? Like skin, for example. Once it crosses the skin, you have a splinter. Think of a splinter. It's crossed the barrier. It's in the skin. And let's pretend that that splinter's got some bacteria on it. So the splinter itself is a foreign object. Now the bacteria is contaminating that wound site. So now you've got to do something about it. Well, we can see that the first response here to injury, and we can read that list. We've got Bacterial infections, start there because we're talking about the splinter with bacteria. Different types of toxins, or trauma, that could be like, you know, steering wheel hitting the patient in an automobile accident. And then the first one on the list is infarction. So what the heck does that mean? An infarction is referring to blood flow to the organ is cut off, and so now there's hypoxic conditions and ischemia causing local tissue trauma. That's what infarction means. Most commonly it's referred to an infarction of cardiac tissue, or what's called a myocardial infarct. That would be a heart attack. But you can have kidney infarcts, you can have infarcts in other organs, but oftentimes we hear about heart. So that causes injury, and you can see in the acute phase, which is what we're kind of wrapping up in this lecture, and then we're going to shift over to chronic. In the acute phase, you can see that the neutrophils are the first ones that show up. They're our first responders. You've got vascular changes. You guys remember the vascular changes that we talked about? And then you have cellular changes, and you recruit these cells into the area, and these mediators, that terminology of mediators, that's referring to the chemical signals that those local cells release, as well as what we're going to learn about here in a minute is circulating chemical signals that will happen, in addition to the local cells sending out these signals. Now, this can actually resolve over time, and that's normally what happens in you and I, is this inflammation event resolves and you return to normal tissue function. It looks like it used to. It behaves like it used to. You've got clearance of the bacteria or whatever was causing the injury. The mediators, those chemical signals like histamine, they subside. They drop down. Instead of having this monster vasodilation, now you actually come back to homeostatic norm. You can see the difference between the two pictures. One has a vasodilated capillary bed on the left, and this one is not vasodilated out. It's more back to homeostatic size. Well, the other direction this could go is down this way, where that inflammatory burden stays elevated long term. And that's a state what we refer to as chronic inflammation. So everything about acute and chronic inflammation are very similar, except for time. Chronic inflammation means that this doesn't resolve. It doesn't go back to resolution. It stays in an inflamed state. And you can see that there's the persistence of the injury. And this is the situation that we saw with our very first disease that we characterized. What was that? Barrett's esophagus. You guys remember me telling you some of the stats? Like, if you have gastroesophageal reflux disease that's persistent for like a decade, that's chronic inflammation. That's not acute. Or you have heartburn every once in a while and it goes away, that's acute. But if you have consistent irritation, that is chronic inflammation. If you have consistent irritation of your joints, right? Let's say in osteoarthritis in our older population, we've got some patients that have joint bone on bone, okay? Some of our athletes, as they get older, they have injury in the joint, and now this injury has persisted for years. That's a chronic inflammatory situation, okay, in those joints, and that's an osteoarthritic inflammatory event. Asthmatics. If you have asthma and you're not managed medically or pharmaceutically, you're not taking care of your airways, you can have chronic inflammation of the airways that persists for years. You're wheezing all the time, okay? Take our smokers, our smoker population, right? Take our vaping population. Ooh, he's going there. Not yet, but we will. And this class is interesting because you can imagine when vaping first came on the scene and we went to the respiratory section, it took us forever to get through that lecture. It's so like, is it safe? What do you think? Should we not be doing it? You know? So we'll get there. I'll just tell you this. And I said this back then. We were not designed to inhale air that you can see with stuff in it. Doesn't matter what it is. Like, that's not how we're wired. So back then it was kind of a question of, is it a safe alternative? I don't know. We don't really know. Right? There was a point in our history, most of you are too young to remember this, where smoking was considered safe. Like you go to a restaurant and everybody smoked. You go to an office and people smoked, whether they were smoking or not, they're smoking in front of each other. And then they started segregating the restaurants. Like, I'll take a non-smoking section. And there was like a strategic row of like house plants between the smoking and the non-smoking section, right? And now we've banned smoking like in public places, or like 50 feet from this intake, vent for this building, right? So chronic inflammation, whether it's smoking, vaping, asthma, bone-on-bone rubbing in the joint, okay, Barrett esophagus, all of these things stimulate this mononuclear cell infiltrate to persist. They stick around for a long period of time. And then they start to change. We're going to talk about how they change. They actually gang up and form what we call foreign body giant cells, and we'll get there here in a second. And also causes trauma to the tissue as it remodels, what we call fibrotic scarring. And the fibrotic scarring means that the body is trying to lay down new tissue to replace the old tissue, but it's non-functional tissue. So what that means is if you have scarring of significance in the skin, and all of us probably have those lesions, it no longer has skin functionality, right? So what does that mean? Well, there's probably no hair follicles, there's probably no sweat glands, it doesn't have the elastic recoil like normal skin, it aesthetically looks different. Well, that happens like in heart tissue. You get a myocardial infarct that scars or have a fibrotic scar. You might have heard of this. Well, grandpa had a heart attack, and they're worried about how much scar. Well, what they're worried about is how big the infarct was and how aggressive it was to determine if non-functional cardiac tissue was laid down. That's the scar. Non-functional cardiac tissue means it doesn't have contractile nature anymore. It's stationary. So now the cardiovascular mechanics are altered of the myocardium. So as it quote unquote heals instead of resolves, it goes into this loss of function remodeled fibrotic lesion. And then there's this one state which is kind of this intermediary that you can see up here, where we're kind of characterizing where the pus comes from. Most of this pus comes from these neutrophils that infiltrate. And so this is the slide that I've shared with my teenage daughters about where pimples come from. So these are pimples. This is where pimples sit. Is you've got bacteria, okay? So then you get recruitment from the vasculature. You have vascular changes and you have cellular changes, and you recruit neutrophils. Neutrophils go into the area, they find the bacteria and they kill it, and they release cellular debris and they create exudate, which is pus. And then you pop it and out it comes, right? So you can write right here, this is a slide that characterized 13 to 19-year-olds right here. Okay, I got 3 of those in my house. So they didn't love this slide, and I don't think they really understood it, but I tried to explain to them, this is where your pimples come from. Any questions? Okay. But I mean, a pimple is a great example of an inflammatory event, right? You got everything there. You just can't see the neutrophils, but you can see what they make. That's the whitehead. That's the pus behind the squeeze, or in front of the squeeze, I guess, right? You're like, gross. Yeah, but you'll never forget it. Okay. That's the whole point. Okay. So now moving from that discussion thought to this slide. So let's talk about where these chemicals come from. We talked about histamine, we talked about all these different chemicals. Like we've talked about VEGF, okay, that's being released by the cells. So at the site of inflammation, we have the injured cells that are releasing some of those chemicals, and we characterized that last lecture. The leukocytes that move into the area, right? These leukocytes that move into the area, they release some of these mediators. We also have mediators that are circulating in the bloodstream, and that's plasma. That's the plasma category. So local cells at the site of injury, what are there, what are recruited, and then also circulating in the vascular supply, in the plasma. And when they circulate in the plasma, they're coming from a number of different places. Where they can come from is either from cell-derived, right, which would be the site of inflammation or circulating the plasma, or they can come from a plasma source which only circulates in the plasma. So if we look at the list that is cell-derived, we can look at an individual cell. Let's take a leukocyte, for example, like what's shown at the site of injury. These leukocytes have these internal packages, right? These internal secretory granules that can fuse with the membrane and they can dump their contents. And we see two main chemical mediators that come out of these leukocytes as they dump the contents, and those are histamine and serotonin. And you can see the sources like mast cells, basophils, platelets. They will dump these types of chemical mediators. And then they also have the ability to manufacture these chemical mediators. And that's what newly synthesized is referring to. So you can see all of the different mediators that are made. And we're going to get to some of these that aren't familiar, but look at reactive oxygen species, right? White blood cells, leukocytes make reactive oxygen species. We looked at that in detail, and it's on the list. We're going to look here in a second at prostaglandins, leukotrienes. We're going to look at those. We looked at nitric oxide when we looked at reactive oxygen species. And then the neuropeptides and these other categories of cytokines we probably won't touch. But you can see the sources of these newly synthesized chemical signals are from the usual suspects that we would have in the area of injury or circulating in the plasma. Right? Now macrophages are only at the local site. So when it says macrophages, we're only talking about the local tissue response. But the leukocytes, that will all be circulating. EC refers to endothelial cell. That's what the EC abbreviation is. Okay? Now let's look at how we can make stuff from the liver, and then it dumps it into the plasma to circulate around. And we're going to look here in a minute at this complement category of mediators. And it's called complement because it was labeled that because it complements the inflammatory process. And so that's why it was labeled complement. Sometimes scientists aren't all that creative, right? They just label stuff based on what they think it does. And then factor 12, or the Haidman factor, we're going to look at the kinin and the coagulation system. So the spoiler alert here is, this is all related to blood stasis. This is an important concept to understand. We introduced it in the last lecture, but I'll go over it one more time. So if we have a blood vessel, and we want to marginate, we want to recruit a cell that's going down the middle of the blood flow, we want to marginate, move it to the edge where it's going to touch the endothelium. We can actually trigger a controlled coagulation or controlled clotting, meaning it doesn't cut off blood flow completely, but it creates a thicker blood so it slows things down. That makes it easier for that cell to find the edge. Does that make sense? And it's this system, the coagulation system, or the coagulation cascade, that's going to provide that activity. So in a couple slides, we'll look at that. So first up, let's talk about these prostaglandins, leukotrienes that are on this particular slide. So we've got a couple of different mediators that are created here, and they all have this common ancestor known as arachidonic acid. And this is a busy slide, I understand. And we're going to walk through, we've got 3 busy slides in a row, and so we're going to walk through them very slowly. But arachidonic acid is really the key ingredient for manufacturing these chemical signals. And so you've got arachidonic acid, which can go down this pathway to the left and become a family of what's known as prostaglandins. Okay? The prostaglandin box is down here. So PGD2, PGE2. But you don't necessarily need to memorize all the different isoforms of prostaglandins. It's fine for you just to remember prostaglandins come from arachidonic acid. Okay? Arachidonic acid makes a prostaglandin, which stimulates, its activity is vasodilation. It increases vascular permeability. Got it? Arachidonic acid also, through this pathway, can become a prostacyclin. And if it's a prostacyclin, this also stimulates vasodilation. So these two have a similar type of activity. Now this one, this pathway, thromboxane, this causes platelet aggregation and vasoconstriction. It's like, well, wait a second. Why are we doing vasodilation with 2 and vasoconstriction with 1? So when you send a vasodilation signal to your vasculature, you want to make sure that you have some sort of regulator in place so you just don't vasodilate out of control. So that's the brake mechanism. Does that make sense? So you're vasodilating, but you have some sort of resistance where you're not overdoing it. It's like kind of like a regulator. Okay, now we back up to arachidonic acid and we go to the right. So arachidonic acid through 5-lipooxygenase creates a family known as leukotrienes. And leukotrienes increase vascular permeability through a different mechanism than vasodilation. So one of your classmates asked a question which was very thoughtful this morning in office hours. There's 2 layers of cells, right, that surround the vessel. And so the first layer that we talked about were these endothelial cells. And so let's draw that again, right? And this is the location, these junctions between these endothelium is where we can actually leak stuff. Well, there's a whole other layer that sits out here. And what are these cells that sit outside of the endothelium? What are those? These are smooth muscle cells. Okay? So vasodilation primarily targets, not only, but primarily the smooth muscle cell. So the smooth muscle cell is going to cause that vasodilation to take place. Now, you can have activity here on the endothelium where if this dilates because these are connected, they're going to start to pull apart. But I could actually stimulate through a leukotriene vascular permeability to go up independent of smooth muscle cell activity. And how could I do that? I wanted to have a different pathway that caused bigger holes between endothelium without touching the smooth muscle cells. Any ideas? Change the cytoskeleton of the endothelium. So what if the endothelium started looking more like this? Does that make sense? So they round up. And independent of what's happening with the smooth muscle cells, you've just increased vascular permeability by allowing more fluid to flow out. Okay, so that's the leukotriene family. So what's nice about this slide is all of this comes from arachidonic acid. So arachidonic acid right here gives rise to prostaglandins, prostacyclines, thromboxanes, and the family of leukotrienes. Don't worry about these guys. We're not going to touch on them. Okay? So I really want you to understand this box right here, vascular permeability. You can kind of ignore vasoconstriction for now, or bronchospasm rather. So vasoconstriction, which is interesting, it increases vascular permeability on the endothelium. It actually kind of causes slight vasoconstriction, which is interesting. But that's another one of those checks and balances for the vasodilation that's happening over here. So you need to understand the activity of leukotrienes on endothelium and slight vasoconstriction on smooth muscle cells, the activity of prostacyclines, thromboxanes, and prostaglandins, all coming from arachidonic acid. Now, where do you get arachidonic acid from? Where in the world does arachidonic acid come from? So you can read this slide if you want to just answer it from the slide. Where does it come from? From the cell membrane. So the cell membrane is rich in phospholipids, which are fats. And so we can use a phospholipase and digest some of the cell membrane to give rise to arachidonic acid, which is the precursor. Now, a clinically relevant question for you, because some of you are like, holy crap, I could care less, okay? Let me tell you why you're going to care here in a second. This is a whole network of how inflammation is executed. Okay, so you have trauma and you have inflammation being a problem. You sprain your ankle, you throw out your back, okay? You work out a little aggressively, you're overly sore, okay, overly swollen or you're in pain, and there's inflammation. What do you do functionally? What is your next response when that happens? Maybe not you, but what about dad? Huh? Ice? Anything else? What's that? Elevate? Elevate your back? Okay, well, elevate your ankle if you, right? What'd you say? Ibuprofen. Okay, aspirin. Okay, an anti-inflammatory. Has anybody done that? Okay, so let's look at this graph here for a second. So these COX-1 and COX-2 inhibitors, they block cyclooxygenase. For example, like aspirin and other types of anti-inflammatories. And so by blocking cyclooxygenase, you prevent arachidonic acid from going down this pathway of making prostacyclins, prostaglandins, and thromboxanes. So you block this entire left side of the inflammatory tree. Does aspirin or ibuprofen block the formation of leukotrienes? No. But have you ever had this? You break an arm or you have surgery, okay? You have your wisdom teeth taken out. You say, hey, we're going to give you some ibuprofen. But what happens if it's not strong enough is what the terminology is. Then what happens? What's that? They'll give you steroids via prescription. So look at where steroids block. They block the conversion of phospholipids to arachidonic acid by blocking phospholipase activity. So they're up in the tree and they block both branches of inflammation. Does this make sense? So that's why if it's not strong enough, which is really not the right terminology, it's not broad enough, right? Anti-inflammatories like COX-1, COX-2 inhibitors, they're not broad enough. They don't have broad-reaching anti-inflammatory activity like a steroid, which will inhibit the formation of arachidonic acid and block all pathways. You guys with me? Questions? I saw some hands.
So are all NSAIDs cyclooxygenase inhibitors?
For the most part, yeah, I would say yeah. The ones that we're going to come in contact with. These NSAIDs are COX-1, COX-2 inhibitors. Is there another question in the back? Okay. Yes?
Question. What about when they ignore the whole inflammatory thing and use narcotics instead for treating pain?
Yeah, so this is treating, so when you take an anti-inflammatory or steroid, you're actually trying hard to address one of the underlying issues, which is you've got inflammation that's out of control. And so if you have high inflammation, you're going to stimulate substance P release, which binds to nociceptors, and that triggers the pain pathways. So at least when we do, prescriptions with respect to lowering inflammation, or in the case of a steroid, obliterating inflammation altogether, we're at least making an attempt to try to get a little closer to the root cause. But you're not fixing what's causing the inflammation. Does that make sense? Okay. Now, if you go just to a narcotic to treat the pain, you do nothing to the inflammation. You're just masking. The inflammation's still there, it's just your brain doesn't interpret the pain. Yeah. So, of shades of gray, narcotics are probably worthless. Steroid treatment is second worthless. You really got to get down to the root cause. So what we'll see, like in the space, for example, a great example that's coming out right now in medicine is a lot of joints are being injected with, have been classically injected with corticosteroids for osteoarthritic joints. And it completely obliterates inflammation, but the problem is you need some inflammation to promote wound healing. And so you get a corticosteroid injection in the knee joint, and the patient feels really good because the inflammation goes away. But then like 3 months later, they hurt like crazy. And now the joint is completely macerated because you just completely eliminated the ability to promote wound healing by eliminating one phase of wound healing, which we'll talk about on Wednesday. We'll talk about the different phases of wound healing. So you can't make inflammation go away completely. Some of that inflammation is not bad. You might want to suppress it, but you don't want to get rid of it altogether.
That's why I wondered if in some patients maybe it's better to use a narcotic for a short period of time
And that does happen. So there are some surgeons, that's true, some surgeons will say, it's tough now because of all the publicity on narcotic overuse or overprescription. But that's why in some cases of surgeons, they'll say, I don't want you taking any aspirins or any ibuprofens. Take Tylenol, because Tylenol is not an NSAID. Tylenol has no activity on this pathway. And that's why Tylenol is being used in a lot of medications, because it doesn't block any of this. I should say that. So that's why they'll reach for Tylenol post-surgery. Now, Tylenol with codeine is a pain reliever with a little bit more of a kick. But the problem is now that's where the addictions are happening. Yeah. But the rationale for that was good in the beginning, which was let's mask the pain for a period of time, let inflammation do its thing, and then as that kind of calms down, you can take away the Tylenol with codeine, just go to regular over-the-counter Tylenol, and then eliminate Tylenol altogether. And it was good rationale. It's just patients were overusing their narcotics. Okay, last busy slide, and then we'll, oh no, I lied, 2 more. This one more. Sorry. So plasma mediators, this is the complement cascade. So like I said, with complement, it was named such because it helps or it complements the ability of the inflammatory system to work. And so the way that it does this is by providing additional signaling. So its factors induce an increase in capillary permeability and vasodilation. That should be obvious now why that's beneficial. Now you're going to recruit these cells out of the vascular supply. It promotes leukocyte activation adhesion, and it promotes chemotaxis, where the leukocyte figures out how do I get to the target tissue that's damaged. Complement helps facilitate that. And then it helps to facilitate phagocytosis. So phagocytosis is this activity of ingesting a fragment or a particle or a bacteria. And complement helps to facilitate what's called opsonization, but it makes that phagocytic process more efficient. We've got 3 different pathways that can be used for activation. An alternative, a classic, and a lectin. And they're shown up here. What I care about isn't that you memorize all the different pathways and the idiosyncrasies between them. What I care about is that you remember the outcome. They facilitate, they merge, all 3 of these pathways merge and facilitate the inflammatory response, phagocytosis, and then actually lysis of the microbe. This one's kind of cool. So what they do is these complements, this C3b, organizes in the membrane itself. It organizes kind of like, transformer style, where it organizes and it creates a channel, and now all of a sudden the channel lyses the cell because there's a giant hole in the membrane. So it literally inserts C3b protein, complement protein, and makes a channel, and then now the whole cell gets sliced. All this fluid rushes in, and it blows up. It's pretty kind of cool when you think about what's going on with biology. The other thing that I want you to take home is I don't want you to care as much about that there's these 3 pathways and understand the idiosyncrasies. I'd like you to know that there are 3. But I want you to appreciate this fact. You're going to see this a lot, and you already have, and maybe a professor hasn't pointed this out. In our bodies, there's typically systems that are very important. And if they're very, very important, usually there's redundancies. And so if there's multiple ways to get to the same outcome, that should be a huge sign to you that that was probably a critical process for us to make sure works well. Does that make sense what I'm saying? And so if you go back to this previous slide, I'm surprised someone didn't ask, like, why is it so complicated? Why are there so many different ways to do inflammation? Well, think about what I just said. If inflammation is so critical to the survival of our species, and you only had one pathway for it to work, and there was a mutation or something didn't work, then you're kind of screwed, okay? Same thing with complement. 3 different pathways that have been discovered over time. And that's why, the classical pathway was the first one that was identified. And then the alternative pathway, probably, I don't know, but it was probably discovered, the alternative was found in, 1947 or something like that, right? And then this was just a lectin pathway using mannose that's completely unique from those. So that's the history. But the idea is all three of these methods are necessary to enable us to have functional complement. That means that it's pretty important. Okay, this is the last really busy slide, and then I have a summary slide for you that kind of characterize all of the mechanisms that we talked about in a little bit more of a bite-sized format. So, plasma mediators. We've got the kinin system, and we've got the coagulation cascade. And the kinin system's on the left, and the clotting cascade, or the coagulation cascade, is on the right. And these are somewhat interwoven. So if you look at the kinin cascade, what happens is you've got factor 12 that's the father of everything. And factor 12 is converted to factor 12A. And in the conversion of making factor 12A, it becomes activated factor 12, or Hagman factor. Factor 12A stimulates the kinin cascade as well as the coagulation, the clotting cascade. And pre-calcrein becomes calcrein, and this feedback's here to shut this off, okay? Or I'm sorry, feedback's here to turn this on. And then it goes and feeds into this fibrinolytic system, which converts plasminogen over to plasmin. And plasmin has two activities. Plasmin actually turns on the complement cascade that we just learned about, and plasmin also stimulates the formation of fibrin. Okay? So you've got this kinin system that is a positive feedback loop here to make this go again and again and again. And down here, you've got two outcomes. You've got stimulation of complement, which we just learned about, and we've got the stimulation of fibrin, which we haven't talked about quite yet. Does that make sense? So that's the left side. Now let's look at the right side. Still, the father of this mechanism is Hagman factor, factor 12 to 12A. We went down this pathway. Now let's look at what happens here. 12A takes factor 11 to 11A, 10 to 10A, and this is a whole cascade that's skipping a bunch of different events sequentially, like 9 to 9A, so on and so forth. Eventually you get down to prothrombin to thrombin, which is 2 to 2A, and then you go from fibrinogen to fibrin. But you had fibrin being recruited by plasmin, and the whole role of fibrin is the early framework for a clot. So when you have a bleed, okay, you have a cut or a nosebleed, the first matrix that's laid down is a fibrin matrix. And so it's really important to be able to form a fibrin matrix in order for you to stop blood flow for hemostasis. Otherwise you'll bleed to death. Okay, so again, there are two mechanisms by which we can generate fibrin, right? We can generate fibrin through the fibrinolytic system, or the kinin cascade, and we can generate it through the clotting cascade. Does that make sense? So again, another example of the ability to form fibrin is pretty important. Now, there are a lot of folks walking around today that have a blood clotting disease. And typically, most commonly, is on this side of the tree. They're missing some factor conversion in this process. And when they can't do this, they have a limited ability to make fibrin. How are they still alive? Well, they're very careful, okay? True, they don't get cut, they're very careful. But do they still have the ability to coagulate their blood to some extent? They have a backup system, just like what we talked about. So if you're interested, Google some of these blood coagulation diseases, like hemophiliacs. There's a lot of them out there, and all sorts of different variations. So here's a perfect example of why this is so important to understand that there's these two trees, right? So we don't put up these cascade of mechanisms like this just to put you to sleep or make your life miserable. There's actually a lot of important reasons that we need to know all of these backup mechanisms. So why do we care in inflammation about coagulation? What's the connection? Where is a hemostasis or controlled clotting of blood important in inflammation? What step is that important to? Marginization.
Is that about getting the from the bloodstream to there?
It's about getting that's correct, it's getting the leukocytes out of the bloodstream going towards the edge of the vessel so they can leave, they can extravasate out. Make sense? Okay. Here's a summary slide that kind of talks about what we just covered, but in words. So you can see up top, we've got vasoactive amines. We've got vasoactive amines like histamine, released by mast cells, basophils, platelets. They function to increase vascular permeability. It allows the white blood cell, the leukocyte, to exit out of the bloodstream and into the tissues. You've got serotonin, that comes from platelets. It helps regulate hemostasis and blood clotting. I don't think I mentioned this, so I should say it now. I'm glad that I had this slide. So the 4 families that come from arachidonic acid, they're actually known as eicosanoids. That's the family class that all come from arachidonic acid. So the eicosanoids that are derived from arachidonic acid are prostaglandins, prostacyclines, thromboxanes, and leukotrienes. And they have vasoactive effects, meaning they cause vasodilation or vasoconstriction. They do cause bronchospasm. You don't need to worry about that, but just for sake of completeness. And they stimulate chemotaxis. And then complement, increased capillary permeability and vasodilation, leukocyte activation, adhesion chemotaxis, and phagocytosis. And then lastly, the kinin and the coagulation cascades. Okay? Heavy on the mechanism. So let me pause for a second and see if there's any questions over this mechanistic section that we just covered. In the back, yep.
I have a question
On the eicosanoids.
that you're talking about.
Yep.
So like if you're an elderly person and you have a stomach ulcer, you're not supposed to take NSAIDs.
Yeah.
Which is weird to me because it can cause like severe bleeding. But if it blocks the path that causes vasodilation, why would that happen? Because it's blocking the thromboxane mostly, or
So are you asking, is your question, why are they saying if you have a stomach ulcer, don't take NSAIDs?
yeah, because if it blocks the vasodilation,
Right.
it causes stomach bleeding.
It's a great question, but it's a much more simple answer than this slide. So the reason that, so NSAIDs are very rough on your stomach lining and your intestinal tract. And so if you have an ulcer, they will tell you to stay away from them. It actually has really nothing to do with this particular tree. I mean, it's a great question. I see why you asked it. Because you can see that there might be some benefit, right? Is that what you're saying?
Yeah.
It seems like it could be beneficial because it would lower inflammation. But the problem is, like ibuprofen, aspirin, a lot of the NSAIDs are really disruptive to your stomach lining. So most often they'll say take with food if you get prescribed like high doses of NSAIDs. So like if you get like the horse pills of NSAIDs, like the 800 milligrams, which is typically 4 of a normal ibuprofen that comes from the grocery store. So those are 200 milligram pills, those little like brown ones. Or like Advil, I think is like a pill that's an orange pill. They're usually 200 milligrams. So if you post-surgery, they give you NSAIDs, they'll give you usually a prescription of 800 milligram pills, so you're not taking 4 of them. And they'll say on there, take with food and water, because it irritates your stomach lining. Good question. Okay, let's shift into chronic inflammation. So, these events are very similar to acute inflammation. The difference is they last a long time. So I've got a graph here. I've got acute on the left, and I've got 2 graphs. Acute on the left, and I've got chronic on the right. So what I want you to take away from these 2 graphs is that in the acute phase, look at this, this is days after wounding. And then over here, this is more like weeks, okay? And so we've got this maximum response. We see inflammation is really our first phase of the healing response. And then we've got this phase 2, which is where we've got cell proliferation. And then phase 3 is where we have matrix remodeling. And that, in a nutshell, is wound healing. That's like the next section of what we're going to talk about. We'll talk about that on Wednesday. You'll have some of those questions on the post-quiz on Friday. And then we'll finish it up next Monday. But this graph on the left that shows inflammation in the acute phase, you see how it comes up and then it goes down? That's the key. Acute means it comes up and it comes down. You can see that there's all sorts of activities like macrophages that show up in this phase, okay? And then we've got phase 2 of wound healing. In the acute phase, inflammation goes away, and then cell proliferation, like new fibroblasts come in, and new blood vessels come in, and you make new matrix, like laying down collagens and fibronectin, and then that goes down. And then you remodel this so it has an increase in tensile strength. You lower the vessels that came in because you don't need them anymore. You remodel this, and after about a year, a wound is quote-unquote healed. So if you have a surgical incision, you have a cut, you have a wound, you can influence it favorably for about a year. What do you mean by that? Well, you can put topical ointments and creams, and you can influence this remodeling phase for about a year away from the injury. Then after that, it's considered an old scar. Now over here, we've got chronic. You can see the neutrophils are the first cells to show up. They're the first ones that show up over here too. They come up and they come down. But then look at the second responders of the macrophages, which show up here, but they come down. They come up and they stay elevated and they never go away. Neovascularization is a word for new blood vessels, and it stays elevated. So this line's flattening like this means that it goes up, stays elevated, and persists. Same thing with foreign body giant cells. We'll talk about those here in a second, but basically they're a bunch of macrophages that fuse together to form one giant cell. Fibroblasts come in and they stay elevated. Fibrosis goes up and stays elevated. The only thing that really goes away in chronic inflammation is the neutrophils eventually leave the scene. Okay, so let's take a look at some examples. So there's 3 main characteristics of chronic inflammation. So number 1, you've got inflammation with mononuclear infiltration. So you've got these macrophages that stay in place. And that's picture A. That's the top hematoxylin eosin slide. And you can see that asterisk, that yellow asterisk, which is pointing to this mononuclear infiltration. Those are the collection of chronic inflammatory cells in that yellow asterisk right here. All these purple dots. You've got tissue damage that takes place. And then you've got healing, like repair, angiogenesis, and scarring, or fibrosis. And this top picture with the yellow asterisk is lung epithelium. And we can see that there's a couple of other things that are labeled there, like these arrow heads. And that's normal alveoli spaces that are being replaced by cuboidal epithelium. And then we've got the arrows themselves with the stem on it, the arrow, and that's connective tissue or fibrosis. That's the scarring. So this is all scarring here, this is all scarring here, and these are new epithelium that's metaplastic in this particular case. Down here, that's acute inflammation on the bottom. So you can see that there are an increase in the number of inflammatory cells, but these are all neutrophils. You say, well, so Dr. Keller, how do you know that they're neutrophils versus up here where you said they were macrophages? Because you can't really tell the difference between a purple dot and a purple dot. So what are some clues to give you on how they're organized? It can help you determine the difference. You see how these are clustered together? You see how these are all spread out? These are all neutrophils that are eventually going to subside. This is an acute inflammation. the red borders are all blood vessels, and the white open spaces are the alveoli, and you don't see any of the scarring like you see with the arrowheads, and you don't see any of the, or the arrows, and you don't see any of the metaplasia that's taking place with the arrowheads themselves. But most definitively, this is nicely densified and organized into one location. These guys are all spread out. So in chronic inflammation, our neutrophils are our first responders. We've said this at least 4 times, right? At least 4 times. The neutrophils are our first responders. So that's time number 5. So you think that's an important concept to remember? Very much so. The monocytes become activated tissue macrophages. They leave the bloodstream and they're recruited to the tissue and they turn into tissue macrophages. And the symbol for the tissue macrophage, again, is like that. And they're our second responders. Then we've got lymphocytes, B and T cells that show up. And we're going to talk later in the semester about the immune system and the role that the B and the T cells play. But understand that they play a role for specific immunity. B cells making antibodies, and T cells attacking. And what are they attacking? Foreign stuff, okay? Bacteria, viruses. And then we've got, we've got eosinophils and mast cells. And these eosinophils and these mast cells can make these cytokine messengers that we've been learning about. All right, let's take a look at this particular slide. This is a granuloma. A granuloma. And it looks a lot like what we saw right here. But this is further along, higher magnification, and we've got a little bit more evidence of a few other things that are associated with chronic inflammation. So, you've kind of got this collection right here. You guys see this border right here? So we got this walling off. There's something in this area that's being walled off. And these cells, at this stage, when they start walling things off like this, another name for them are epithelioid cells. So these are tissue macrophages that are starting to wall off a particular object or entity, like a bacteria or a virus. And then these blue arrows are pointing to some unusual large cells. We call them foreign body giant cells, or FBGCs, foreign body giant cells. And the master of the foreign body giant cell is a guy by the name of James Anderson. And he first described these foreign body giant cells as they relate to chronic inflammation, particularly around biomaterials. We're going to talk about that. And in these responses where you've got these epithelioid cells, and we've gone for a long period of time from this upper picture, and now we're at this picture, these epithelial cells or these tissue macrophages, they fuse because they're trying to phagocytose or engulf the foreign object and they can't do it. So they join forces, they fuse, and they form a multi-nucleated foreign body giant cell. So like, it's not unusual for a foreign body giant cell to have 10 nuclei inside of it. So that's 10 macrophages that just fuse. It's like if the first 3 rows became like one human right now. Would that be weird or what? And your brains are nuclei, so we can tell that there's 10 of you because there's 10 brains. And so you can see, if you look carefully, that there are individual nuclei in these foreign body giant cells. That is a telltale indicator that you have chronic inflammation. Typically in chronic inflammation too, you might have a little bit of a necrotic core in the middle. Right? That tissue in the middle that's being walled off may not be getting a whole lot of blood supply. All right, here's another example, like in the spirit of James Anderson. So this is work that we did in my lab. And you probably, if you're up late at night and you're watching like, infomercial on knife sets and how to buy an exercise machine for 3 easy installments, you might get a commercial that comes up on like polypropylene mesh. So polypropylene mesh has been identified in more recent present as being extremely inflammatory. But they were making, a lot of companies made a lot of medical devices out of polypropylene mesh, primarily hernia patches. They're making hernia patches or urinary slings or patches of material that were used for like vaginal reconstruction. And unfortunately, they're not very bio-friendly, the material. And so it stimulates an aggressive chronic inflammatory response, and then the body tries to push it out of the tissue. And so patients were complaining of pain, and they'd go and take a look at where the hernia mesh was, and it was like sticking out of the tissue because the body's trying to get rid of it. They wall it off, and then it pushes it out. So we had a project in the lab where we're trying to take polypropylene and find a coating. So this is a human extracellular matrix coating that we used. And we took a hernia patch and we coated it with a human matrix so it would hide it from the body, essentially. It would make it look like it wasn't there. And you can see all of these foreign body giant cells in a non-coated example. And then, so this white area is where the polypropylene fiber was sitting. And you can see a significant reduction in the number of foreign body giant cells in the coated polypropylene mesh. So, segueing into the last section for today are these biomaterials. So I'll talk a little bit more specifically about how we did this. So I want to flash back. This is James Anderson. So this is that slide that I showed in the very beginning of chronic inflammation. So giving credit where it's due. This is a 1988 publication. Okay, some of you were like, holy cow, dude. I didn't know you had pen and paper back then. So I know this predates most of you, but this is like a classic chronic inflammation slide. So this is not in your textbook. This is old school. This is straight out of the literature. This is like one of my heroes. And this is that figure that we show. We show acute and chronic. This is the chronic figure. So you can see you've got acute, you got neutrophils coming in and they fade. And then you've got macrophages that stay up, elevated. You've got blood vessels that are elevated. And I've circled for your convenience foreign body giant cells staying elevated. And so Anderson published that this is one of the critical things in biomaterial functionality that we need to get around. So we've seen this in all sorts of spaces within biomaterial research. This is back in 2001. And these are tissue reactions to polypropylene mesh in oral maxillofacial surgery. And what's crazy is, I mean, this is a Brazilian publication, but this publication in 2001 actually predates some of the releases of polypropylene mesh, which is nuts. Like, I know this is a Brazilian publication, but I don't know why American companies never looked at things like this. This is in oral maxillofacial surgery, I understand. It's not in hernia patch reconstruction, but this is the importance of being able to do comprehensive research on a topic. So this concept of pre and post quizzes, I know you guys probably don't love me for them, but it actually is trying to help you. You guys are in the new age of where information is rampantly available. It's not whether or not the information exists. It's whether or not you can figure out, A, can I find it? B, is it reliable? And then C, what do I do with it? So this is a perfect example. In 2001, so these hernia patch lawsuits post-date this publication. So it is a well-known fact that polypropylene is highly inflammatory. So here's polypropylene mesh. Horrible histology. Sorry, I'm just going to bag on these guys. But they discovered it. Now, so here's a foreign body giant cell. You can see the polypropylene mesh with the, it is black and white because the journal publication was black and white, so I'm not arguing on that. It's just like the tissue quality is really bad. But you can see these, bless you, you can see these arrowheads pointing to the foreign body giant cells. So this has been well documented. This is in Silva 2001. So I don't know why these huge multi-billion-dollar companies making hernia patches, pelvic floor reconstruction devices, are employing people like all of us that couldn't find this paper, which is kind of sad. So what we did is we went into the lab and we used a photo-activated crosslinker. This photo-activated crosslinker, you take a polymer, polypropylene mesh, we put a protein on its surface, and we link this protein to a photolinker. We shine UV light on it, and it covalently bonds the polymer to the protein. Okay, so that's how we coated these meshes. And so this is immunohistochemistry showing, we picked fibronectin. So this is anti-fibronectin. I did a slide for you. Where this is the background fluorescence of the polymer, which is just kind of cool all on its own. But this is actually with anti-fibronectin antibody. So we are proving to ourselves and to the company that we could surface treat this polypropylene mesh with a human extracellular matrix. Then you saw this slide, so it was kind of a spoiler alert. We saw this slide already, but it's back to this slide. This is the uncoated mesh, so these open circles, you can see how aggressive all of the foreign body giant cells, basically all the purple dots, all the nuclei, and you can see and appreciate that they completely surround these fibers. And here, we've got one side that's completely absent of an inflammatory response. And it's very slight here, and maybe one or two foreign body giant cells right here, but a significant improvement after 2 weeks of implantation. This was implanted subcutaneously in a rat. So we went on and we could characterize this quantitatively. So we used quantitative histology. So this is the number of foreign body giant cells in the tissue around the polypropylene in an uncoated situation. So minus ECM means there was no coating. And then this is the number of cells around each fiber, foreign body giant cells, so there's a significant reduction after 2 weeks. This is an image analysis looking at fibrous capsule. Remember how I said there's a couple of telltale signs of chronic inflammation. One is a walling off. The walling off is the body's desire to get rid of something that's foreign. And so foreign body giant cells and then a walling off. Well, we can take the original histology image. This is actually a trichrome stain, so that the blue is staining collagen. The blue is staining collagen, and then you'll see in this next picture, we've got eosin, right, staining the tissue. This is the muscle layer that's underneath this subcutaneous skin in a mouse. And then you've got some collagen, some blue that's happening here. And then we've pseudo-colored with an algorithm all of the fibrous capsule around each of the fiber. So that's how we do this. And we can look at the control, uncoated, and then the surface treated or the coated, and again, a significant reduction, a statistically significant reduction in the presence of the fibrous capsule. And so we can take commercially available biomaterials, we can modify them with their surface, and then we can influence how the body sees them with respect to inflammation, which is kind of cool. Yeah, question?
ECM, is that something that the body doesn't reject even though we make our own extracellular matrix?
Yeah, so that was a great question. So the ECM that we use, is that something the body doesn't reject? Yeah, so we use human fibroblasts to grow the ECM that matches the ECM, which stands for extracellular matrix that you and I all have. It's not a problem from a transplant from a patient to a patient because it's acellular.
Okay.
So tissue rejection when you transplant tissues usually happens because of what's called MHC complexes or major histocompatibility complexes that are found on nucleated cells. So if you just take the matrix and no cells, you don't have any antigen markers. It's a great question. But there's no rejection. You would see the rejection if you looked at this particular picture. The rejection, you would actually have necrotic tissue happening around at that interface, at that material tissue interface, you'd have necrosis. Okay, so in summary, we'll finish a little early today. In summary, we talked about inflammation, which is our second line of defense, right? Our first line of defense being physical barriers. We've talked extensively about the characteristics of inflammation. We've compared and contrasted acute versus chronic. And then we've talked about how we can look at an application that might be relevant in our world on how we can modify medical devices, which is something that I like to do. Okay? All right, we're done about 5 minutes early. I'll see you guys on Wednesday.